Kerry, I got a joke for you.
You do?
I do.
Okay.
All right. Now, if the joke is not good, you don't have to laugh, but I found this to actually pretty good. All right. So why did the woman with PCOS fail the grammar test?
The grammar test?
Yes,
Okay.
the grammar test.
Why?
Too many irregular periods.
This is STIRRUPS, Candid Conversations in Women's Health, the podcast where we answer your burning questions and discuss the evolution of women's health through every stage of life. Join Dr. Randolph Scott and duly certified women's health nurse practitioner and certified nurse midwife, Kerry Autry, as they discuss the unique health concerns women face and share expert advice to assist you on your journey to maintaining your health and wellness. If you're looking for informative discussions, tips from qualified professionals, and a community dedicated to women's well-being, then you're in the right place.
It's very true. It's very true.
Punctuation. I'm sorry. I just got that junction function in my head. I'm sorry if nobody knows what that is. But anyway. All right. So let's talk about that. Diagnosis of PCOS. I think it's important to really come up with, or at least have patients understand, how do you make that diagnosis? And a lot of times it's clinical, meaning based upon the symptoms that the patient may express to the provider. Sometimes you get some lab work to support what your clinical experience and what the patient is going through. But for most patients, they're meeting a criteria, and there's usually two of three things that we will see patients have with respect to PCOS. And the first one is the one that we perhaps may see patients the most for, is that your cycle becomes irregular or has been irregular. And sometimes...
Or just stops.
Or just goes away.
Just haven't had a period.
Where did it go?
Yeah.
And of course, after you rule out pregnancy and things like that, that's one of the major criteria in terms of diagnosing. Is irregular cycles. And it's usually less frequent rather than more frequent in terms of cycle. The secondary aspect of diagnosis is patients will have some level of what we call hyperandrogenism. That means elevated levels of testosterone. And sometimes you can see that in a physical appearance. For example, we see a lot of patients that may have facial hair or hair in unwanted places. And that's a huge hallmark in terms of PCOS. And the third thing that we can often see is on ultrasound cysts. And so we got to be really definitive about what those cysts means, how many cysts are present in order to meet that diagnosis. Now, PCOS is really important for us to talk about because I think it's far underdiagnosed for a lot of patients. And then those who are diagnosed, trying to figure out how we can best help them is really the next step in the process. So people want to know what it is and how we can help them all at the same time. And so symptom-wise, we talk about the cycle and things like that, and that's a huge one because the cycle kind of, or the menstrual cycle kind of sets you up for everything else in terms of some of the things that we're actually are trying to help treat all at the same time. Because if you're not cycling regularly, then oftentimes that means you're not ovulating. Mm-hmm. Now, if you're not trying to conceive, it may not be an issue for you. But those who are, infertility becomes a factor as related to PCOS. We talked about the criteria of the hair growth. We have hair growth, face, chest, back, again, in unsightly places, buttock, that you can have. Some patients are curious about the weight gain that they have, and particularly where the weight gain occurs. I mean, it's, centrally located in a lot of times. And that becomes a major concern for patients. Sometimes the acne that you can have becomes a factor. Just oily skin certainly can be seen with patients with PCOS. Because of those levels in terms of testosterone or androgens being elevated, patients will have thinning of the hair, so hair loss. In a very similar way to male pattern baldness. Women can certainly experience that as well. Problems with pelvic pain, particularly if you're forming large cysts that are related to the PCOS. Some patients' skin changes become a factor where you have darkening of the skin around the nape of the neck and other places that can be a factor. Some patients are just not sleeping well, and they're not sleeping well because PCOS patients have a higher risk of having sleep apnea, and so from a symptom standpoint, it can be a lot of things. The unfortunate part about PCOS is that there's no one-size-fits-all medication that we can give patients. There's not one particular thing that you can do, but certainly we can talk about the treatment aspect of things for you. And so what are some nutritional things that patients can do, Kerry?
Well, I mean, like you said, PCOS is huge. The definition for PCOS, the diagnostic criteria for PCOS is very wide. Mm-hmm. So you end up with people all fitting into this PCOS category who didn't necessarily have the same things that got them there.
Right.
All we need are people who don't have periods. Sometimes we see people who have high androgens, sometimes not. Mm-hmm. Sometimes we see people with insulin resistance, sometimes not. But for the vast majority of PCOS patients, I think it's about 70% insulin resistance is what's causing the PCOS symptoms. When I talk with patients about PCOS, I think one of the most frustrating things for them is when they got that diagnosis, it almost sounds like a sentence, like you are now a PCOS person and this is you for the rest of your life. And I just don't see it clinically. I think because so much of it is insulin resistance driven, there is every potential to really reverse all of that and roll it back. You just have to know how. But I always tell patients that, that work is hard. It's hard work and it takes time. But the good thing about it is, 10 years from now, 15 years from now, when I don't know you anymore, if you miss a period or two, you can look around and be like, oh my gosh, I know what it is. I know what I have to do because I have the tools. Yeah. So when patients come to us and they're saying like, I haven't had a period in all this time, and we do some lab work, we take a good clinical history and we say, well, for a number of different reasons, possibly this looks like PCOS. And, I say to patients, we have a couple of different ways we can manage this, depending on where you are in your life, depending on your goals, depending on what you want from this, because your goals are going to change throughout your life. Like this is going to be in the background, but your goals will change. And we have to make sure that what we're doing is meeting you where you are.
I agree with you 100%. You framed that very well. In the sense, I think it's empowering in the sense that you can do something about it. You can, in the sense, you can reverse what's the challenge in front of you that's happening at the same time. And that's what we want to really focus on for the patient is that your role is a huge one in terms of mitigating some of the things that you're going through.
But again, like depending on where you are, that may kind of take a back seat. When I'm talking to a patient who's 16, 17 years old and is in high school and is like, I just need to know that I'm going to have my period on the third Tuesday of the month so I can be prepared. I get that. That's very real. And it's understandable, right? So for that patient, we probably got to put you on birth control because nothing else is going to get you there.
Yeah.
But for a large number of patients who are like, I don't want to be on birth control. When I was diagnosed, they told me I had to take birth control. I've taken birth control all this time and I don't want to do that anymore. I want to try and understand like, where is this coming from and how do I start to reverse this? And when we're talking about reversing the causes of PCOS, we're always going to come back to that ovulation, just like you said. If you're not having periods, you're not ovulating. If we're going to get to the cause of the PCOS and what's causing the lack of periods and all the other symptoms, It's the hormone imbalance that's stopping you from ovulating.
Sure.
So that's where we focus our energy. Now, like I said, for most people, that's insulin resistance. So patients are often told, if you just lose weight, it'll go away, which is I mean, in some ways it's true, but it's a terrible way to approach this. And I try to tell patients, you can hear that as punitive because that's how most of us hear that, to be honest, or you can hear that as empowering. You can look at that and say, okay, like that sounds really awful and it hurts my heart to hear it. But it also means that I have the tools, like I have everything I need to start to turn this around. And we're just going to be focusing on that insulin resistance. So for most people, what that is I focus really strongly on an anti-inflammatory whole foods diet. If you have no idea what that means, that's okay. You go home and you Google Mediterranean diet. Google Mediterranean diet recipes, huge focus on leafy greens, huge focus on vegetables, huge focus on lean proteins. Really focus on getting your protein in because your protein and your fiber are what's going to stabilize that blood sugar throughout the day. And it's a really complicated relationship between insulin and blood sugar and estrogen and testosterone. But the bottom line is we got to get your body to use insulin well and get the blood sugar out of the blood and into the cells. So really, really strong focus on the anti-inflammatory diet, whole food diet. The weight will come with it. But again, if you're approaching this from an empowering point of view, I always tell patients, I don't want you to spend any time thinking about the things that you can't eat. Yeah. Because if you are getting in everything that I'm asking you to get in, there's no room for anything else. If you are getting in the 80 to 100 ounces of water I'm asking you to drink a day, not a lot of time for soda. If you are getting in 8 to 10 servings of vegetables a day, there's not much room on your plate for anything else. So instead of thinking of it as, I can't have all these things, if you think of it as, food is medicine, food is healing, and you're choosing good things to put on your plate, you'll feel it and you'll feel it quickly. And then if you have something that you should eat less of, because I also don't believe in elimination diets, I don't think there's anything that you should never have. But when you have something that you would eat less often, you'll feel the difference and you'll gravitate to the things that are going to make you feel better.
Kerry, that was fantastic. I'm feeling motivated right now. Okay. I'm just going to skip lunch. How's that?
No. That's not
don't do that. Don't do that. Oh, okay.
I mean, how are you going to get in your 10 servings of vegetables
today?
You got to eat lunch.
Okay. All right, fine. Kale for lunch.
So I think there's a lot of power in trying when we look at food as medicine and as true nutrition, as opposed to this enemy that we've sort of created in American society today, that everything is bad except for 3 things, but everything there's no such thing as good or bad. It's really trying to get the right things in the right proportions, and the rest will fall into place.
Yeah. Kerry, that's, the way you frame it is great. But even trying to meet that challenge, as difficult as it can be sometimes, it doesn't usually require, from somebody that is 200 pounds to be 150 or 300 pounds to be 200. Sometimes a small shift, perhaps 10% of your body weight, can make a difference for you. And Absolutely. It can make some changes for you where perhaps that cycle regulation becomes a more consistent and dependable thing that you can count on.
But the other thing is, like, when people have come to see us because they have PCOS, very rarely is the missed period the only thing.
Right.
They come in and they say, I haven't had my period. I feel tired all the time. I don't like the way I look. I have acne. I have all these things. And, the periods tell us a lot. There's a lot of resources out there that call it the 5th vital sign. And it's not a terrible description for women, because it says a lot about what's going on in our hormonal life. Yeah. But, that's just one symptom of all the other things. So as we start to get these things in place, then you can start to feel better. Even if you're, like you said, you don't lose 60 pounds. You don't need to lose 60 pounds to feel more like yourself. Yeah. And then there are some herbal supplements that I use often in practice that can help support the work that you're doing. Berberine is one that I think is really kind of coming into its own. We've used inositol for a long time, and we do still use inositol.
Yeah,
It supports ovulation. So again, we're getting that ovulation back on track to get the periods back on track. Berberine is showing some really great data that it not only helps with the insulin resistance, but it's actually bringing down the testosterone numbers too. So for our patients who are really struggling with the hair growth and the acne, the berberine can help with the insulin resistance, help with the weight loss, and help with those hyperandrogenism symptoms. So I love that. I use that a lot in practice. One of my other absolute favorites for just generalized inflammation, which kind of goes along with a lot of PCOS, is cinnamon. I mean, who doesn't love cinnamon?
Oh man.
Right?
I'm getting a cinnamon roll after this.
I'm like, this is really easy. You make your cup of coffee in the morning, you throw in a quarter of a teaspoon into the cup, pour your coffee on top of it. It's the best coffee. Yeah. And you got a big dose of some anti-inflammatory cinnamon on the way.
Yeah. And you touched on the insulin resistance. That's a huge piece, to PCOS. And sometimes that can be a challenge for patients in terms of trying to get things regulated, trying to reestablish normal cycles, trying to minimize the hair growth and things like that. All of those are a factor. And of course, that's related to the insulin resistance. Your body also creates a hormone called LH. LH will increase the androgens or the testosterone for you too. And that kind of all falls in line. The insulin resistance, I think, improves, as you were saying, based upon your activity and your ability to perhaps lose weight. But I have some patients with PCOS, they're not all overweight. And so, we talked about those three things in terms of cycle regularity, hyperandrogenism, and PCOS with polycystic ovaries. Weight is not a criteria. It's not a criteria at all. And so, but the insulin resistance is still very real. For some patients, it can be, as we're saying, challenges in that. And how do you combat insulin resistance? And so, there's no FDA approved medicine that says this is how you should really tackle insulin resistance. However, a lot of providers will use Metformin. Metformin is a great medication in a lot of ways because it will help reduce sugar production at the level of the liver. It will also help with sugar absorption at the level of the intestine. And all those things help to decrease sugar load within the bloodstream in itself. So Metformin is, a great medicine to help meet that insulin resistance for you when you need a little bit of help. Sometimes when you are exercising 5 days a week and you need a little bit of a boost, certainly that can be helpful. Now, Metformin is a great medicine. It's relatively an inexpensive medicine for a lot of patients. But at the same time, sometimes there's, some side effects to it.
You got to ease people into Metformin.
Right. And so you're exactly right to that. When I start patients on it, I start them low and slow, just like I do anything else. And usually at nighttime.
Oh, yeah.
So that, you're sleeping while
you're not feeling great.
Right.
Yeah.
Getting some rest. And so I think that's a great way to kind of tackle that. The other piece for us, you're right. When we see patients, usually it's a compilation of things that they're going through. Infertility is the huge issue facing a lot of PCOS patients. Because if you're not ovulating, well, guess what's going to happen? Well, or not going to happen.
Right, exactly.
You're not going to.
And you're
pregnant.
Right. That brings a lot of people in too. And sometimes that's how we find it.
That's right.
That people come in because they just haven't been able to get pregnant.
Right.
Until you start asking a few questions and you get to the point where they're like, well, I haven't had a period in the last 6 months. Is that a problem? Well, it's going to make this really tricky.
Yeah.
So we do often diagnose PCOS as we're starting to look at fertility questions.
Yeah. And so we'll certainly talk more about, trying to help those who are trying to get pregnant, trying to conceive. There's some useful things, but the hallmark is if we can get you to start having regular cycles, the cycle is usually an indicator that you are ovulating. And so if we can get you to get regular cycles, that's the jump start for us. And so I had mentioned that, PCOS, Polycystic Ovarian Syndrome, it's a little bit of a misnomer in the sense. When I am looking on ultrasound, I don't see cysts. What I see is a lot of follicles.
Right.
Now, what are follicles? Follicles are where the egg development actually takes place.
In the ovary. So you're talking about looking at the ovaries on ultrasound.
Yes, exactly. Yep. And so we're looking at the ovary in itself, and I will see a lot of follicles. As a matter of fact, for most PCOS patients, to meet the diagnosis, oftentimes you will see follicles in the extent that it's perhaps maybe more than 12 follicles that you'll see. And really the doctor is counting 12 or more follicles that are present on the ultrasound machine. Now, follicles...
Whereas normally we would find, depending on the part of the cycle.
Yeah, depending on the cycle, you're certainly less than 12.
Certainly
right?
less than 12.
Less than 12 as usual. Now, to have follicles present, that's normal. That's part of what your body does. As a matter of fact, it's just worth noting that you're actually born with all the follicles you will ever have in your lifetime. And once you start having your cycle, your body actually goes through a serial reduction for the rest of your reproductive life.
I know.
Those follicals.
I know. I tell people that all the time. Like, we got to be careful. Whatever you were born with, that's what you got.
That's what you got.
And that number goes down every month.
Every month. And we'll talk about what that means for patients as you get older. But you go through a serial reduction of the follicles in itself. And so to have them is actually normal. But oftentimes what we'll see for ovulating patients, there's usually what's called a dominant follicle where the egg is released. And then if fertilization occurs, then pregnancy. If it doesn't, your cycle repeats itself all over again. And so what we look for is multiple follicles on ultrasound to make the diagnosis and not necessarily cysts. Now, because you have in excess of follicles of what our expectation would be, oftentimes those follicles can then develop into cysts. And usually I'm noting cysts because usually even with a dominant follicle or a larger follicle, you can see them at about 2 centimeters.
Right.
So anything
just
that's...
calling it out. A 2 centimeter cyst on the ovary is actually a normal finding.
It's a normal finding.
I know. It sounds crazy. Yeah. And especially if you've ever actually seen it on an ultrasound machine, because they look like golf
gigantic. Balls
as opposed they look huge on an ultrasound picture. But a 2 centimeter cyst is a normal part of the cycle. It's
a normal part of the cycle. And perhaps that could mean that you are actually ovulating. Once I see, quote unquote, a cyst greater than 2.5, 3 centimeters, now we're talking about
something we should maybe follow.
Follow, pay attention to, and see where things go from there. Now, we talked about the cycle too. So, Kerry, is it a problem not to have a menstrual cycle?
Not necessarily. It's certainly a sign that you're not ovulating in the way that we had talked about. So what you were saying, Dr. Scott, when you're looking at these ultrasounds and you're seeing all these follicles that one has not started to get bigger. They're not moving towards ovulation. And that's what I explain to patients is that you're kind of in this place where you're stuck. Yeah. Your body is trying to make eggs and you have a lot of the luteinizing hormone that you mentioned earlier. And that number gets higher and higher because you have all these eggs developing, but we never get that nice big surge, which is enough to kind of push you over to the edge, enough to get you to the point where you ovulate. And that again has to do with the testosterone, has to do with the insulin and the insulin resistance, but they're in this place where they're just stuck. Yeah. And that's why they're not having periods. So what we don't want to see happen is for the lining of the uterus to build up to such a degree that it becomes dangerous. Yeah. So I tell patients all the time, I don't need you to have a period once a month. That's okay. Yeah. I need you to have about 3 periods a year. So if you are a patient who is managing PCOS and you're trying to find your way, especially if you're trying to navigate some of these more complementary approaches, nutrition and herbs, that can take longer. It's okay if you go a couple of months without having a period while you're kind of moving towards a more balanced hormonal state. But if you get to the point where you've gone through, 4 months without a period, you probably just want to reach out to your provider. We can give you a medication, clean out that uterus. We want to time that really carefully, because if you haven't had a period in 3 or 4 months, it's not going to be the most pleasant period of your life. So you want to be careful when you're taking that medication. You don't want to have that period while you're on your beach vacation.
Right.
But you do want to have at least a couple of cycles a year.
There's nothing written in stone in terms of having a monthly.
No.
Doesn't have to be monthly.
Nope.
It's called a monthly.
Yeah.
But that's not necessarily a requirement in terms of your overall health and well-being. Oftentimes I get the question, how is infertility treated with patients with PCOS? And, and even if we can get you pregnant, is the pregnancy high-risk pregnancy? And should I expect, complications that could result from having PCOS and then either A, trying to get pregnant, or B, during the pregnancy itself? Now, to answer the question, can PCOS make it more challenging for a pregnancy? Yes, it can. Does that make it significantly, a more complicated pregnancy? Not necessarily.
I was going to say, it depends. It's the beautiful thing about medicine. We don't like to commit to anything.
That's right.
It depends.
Sit on
Maybe.
the sidelines, on
Could
the fence
be.
a little bit. We're going to punt a little bit for that one. But
we can talk a little bit about what would make it more complicated. But
that's right. Now, it does in the sense that some of the PCOS patients are more prone to hypertensive disorders during the course of the pregnancy. So, of course, you want to be on guard for that. Some patients have higher risk of gestational diabetes. That becomes a factor, during your late second and third trimesters. And even once pregnancy occurs very early on, sometimes the miscarriage rate is slightly higher in regards to patients with PCOS. But it's not anything that I think from a provider standpoint that you should make any wholesale changes initially for pregnancy. Is something, though, to be mindful of. There'll probably be a little star in your chart about your past history and how to manage things for you. So should some of those things become issues for you.
But I think, going back to what we had talked about, towards the beginning of this, is it's not the PCOS necessarily that makes the pregnancy high risk. It's the underlying insulin resistance that can make the pregnancy high risk. Right. So for all those people out there who are doing the work with the nutrition and the herbs and all those things, and they're reversing that underlying insulin resistance, and that's why they start ovulating again, those risks aren't necessarily there. Because remember, PCOS is almost more like a symptom of that underlying insulin resistance for a lot of people. There are other types of PCOS, but that's definitely the dominant one. So the more that you are able to kind of dig in and do that work and find the providers who are able to help guide you through that, the more successful you're going to be both in getting pregnant and then having a really healthy, wonderful pregnancy.
Yeah. And the other part to that, I spoke about, once you do get pregnant, but let's see, how do we help you to get pregnant?
Sure.
That's a huge step for a lot of patients. And sometimes it can be very challenging, even from a provider standpoint. Most of your OBGYNs got a few tools in their bag before we actually get the reproductive or infertility
before
specialist.
We send you to the big dogs.
Yeah. So there's a few things in our arsenal that certainly can help. There's two medications that are very common in use. One of which is called letrozole. That's a medication that is designed to diminish some of the estrogen production and thereby increase your rate of ovulation. For that particular medication, that's a fan favorite for a lot of providers because it doesn't require a lot of monitoring. You can prescribe it. There's usually very little adverse events or side effects as a result of taking the medication in itself. And you only have to take the medication for 5 days out of your cycle. So it becomes a great tool to use to at least get you to ovulate when you had not been ovulating. The other one that's probably more known is actually Clomid. Clomid is a very good medication. It has its own uses. It works a little bit differently than the letrozole, but that can also be effective. And as a provider, I like Clomid as well. And it's something that you can titrate, meaning you can go up in terms of the medication. So you can start patients relatively slow and then increase the dose in order to achieve the desired benefit. Now, oftentimes with Clomid, there is a little bit more legwork. You got to monitor the prospects of you actually ovulating. And we try to do that with what's called a day 21 progesterone level, meaning at the 21st day in your cycle, we try to see, hey, is there a possibility that there was some level of ovulation that took place for us as indicated by those levels?
And that can help us guide dosing.
Yeah.
If we started you off at a low dose, we tried it for a cycle, we get to day 21 and don't see the numbers that we want, very often your provider will say, okay, we're going to have to increase that dose the next time to see if we can get the LH up to where we need it to be.
Yep. Let's touch about some of the other symptoms that can take place for us.
I was going to say one more thing though. Sometimes there's a third medication that we have to use when we're trying to get people pregnant. So for people with PCOS who aren't having periods, very often we have to start with a medication to make you have a period. Then we do the letrozole or the Clomid starting on top of that. So sometimes it can be a two-step process, but providers, it's not something that it's unusual for us to do. We do it all the time, and any provider would easily be able to walk you through that process.
Yeah. You got to get to the period or the bleeding to get started. So that you know how to actually anticipate things from a cycle
really
standpoint.
Just kind of forcing you to do things on our schedule.
Right. I like it.
Yeah.
All right. So what about some of the other symptoms there, Kerry, that some patients will face? Acne, hair growth.
Yeah. So I think it's definitely one of the things that brings people into the office the most is some of these more these skin-related symptoms that we see along with the PCOS. And again, it's kind of in the same place a lot of the other choices for PCOS. Like you have your choice of how you want to manage these things. And different patients will find themselves in different places depending on their priorities and depending on, what's bothering them, what they want to put into it. But when we're talking about acne and hair growth in particular, we can either sort of work on that testosterone piece with like a berberine, or there are prescription medications that we use. Very often we'll use a medication called spironolactone, which does require just a little bit of monitoring. But once we get you to a good dose, you're usually good to go for a while. Tough thing about spironolactone, though, is you do not want to get pregnant if you're on spironolactone. So then we're still back to putting you on a birth control too. So a lot of patients don't like the idea of doing both. But it's really important that you don't get pregnant when you're on spironolactone.
Now, one of the biggest things for patients, once they have a diagnosis and they're not meeting some of the expectations in terms of some of the symptoms that they're having, I want to talk about, what can happen as a result of having PCOS for some patients, and particularly if things are not managed well or they're not meeting some of the goals. PCOS patients really have a higher risk of developing diabetes. We see this in the sense that the risk of type 2 diabetes becomes higher. Even gestational diabetes, we talked about that earlier. Patients oftentimes will be at an increased risk of heart disease. And that can be impactful. Sometimes it's weight related, sometimes not necessarily. A big one for me, and you put this out there in the sense that if you're not having menstrual cycles for prolonged periods of time, sometimes that could be a factor. Patients are at increased risk for developing uterine cancer as a result of PCOS. Some patients are having sleep disorders, as I mentioned earlier, just because of sleep apnea. One of which, is kind of near and dear to me, but that I'm always mindful of is patients are at higher risk of depression and anxiety.
Eating disorders.
Eating disorders is another one that kind of ties back into that. So, I don't think it's one of those things that you can just kind of wash your hands with. Oh, I'm not getting any cycles. That's fine. I'm not trying to get pregnant at this point in my life. And so I just kind of go about things. I certainly think there's a level of attention that you kind of have to give this if that's a diagnosis that you actually have been given.
No, I agree with you. I think, especially when you're talking about that risk for depression, anxiety, eating disorders, all those things, it's one of the reasons that I think it's so important that as providers, we help patients understand what's the underlying cause, what is causing these symptoms that I'm experiencing, and what are my choices to deal with it? Because there's not one way to deal with PCOS, and there's not one way for one person to deal with PCOS their whole life. Right. How we manage that will change throughout your life. And giving them the tools that they need to kind of take that control into their own hands. Because sure, there are some prescription medications that we use, but that's not the only way to get there. So the more that we can empower people to see their agency in starting to make these changes for themselves, and then celebrating those wins with them when they call you or they write me a note and say, I just had a period. Like, who's happy about that? But they are, because
we are.
I mean, we are too, but it's such a sign of the work that they've put in and seeing the changes, that really physical sign of these changes, these positive changes that they're making.
Yeah. Sometimes as providers, we have those small joys, and that is certainly one of them. I know it is. It's almost like your kid running around naked. Mommy, I pooped in the potty kind of deal. Yeah. It's very similar.
Or when one of those patients calls you and tells you that they're pregnant, like, oh man, you just made my whole year.
But you're right. And how can we be helpful, as family members, as husbands, partners, helping patients to help meet some of their expectations? I think it's really important at the same time. So first, the expectations has to be set and met, and trying to help that person get to that point certainly can be beneficial for both parts. We were talking about this the other day as we were talking about preparation. If your wife comes in and says it's going to be a straight veggie night, you gotta give a yay to that. Right. It's got to be.
And just know it's good for your heart too.
Right. So when I think when changes are made, it's not like everybody has to be happy about it, but certainly you have to be supportive about what those changes mean, and helping your loved one get to that next step, and changing things for the better. Because again, PCOS is just not about infertility, and as you said, some of this you can actually scale back, that you can minimize the impact on your life and the lives of others that are around you. So with that in mind, that's our topic for discussion today. Certainly there's more to talk about, and we'll continue to do so. Thank you for listening.
Thank you for joining us on this episode of STIRRUPS. Be sure to send us your women's health questions and topics you'd like to cover by visiting our website, carolinaelitewomen.com. If you enjoyed today's episode, please subscribe to the podcast and spread the word by sharing it. To find out more information about Carolina Elite Women's Care, visit carolinaelitewomen.com. This podcast is edited and produced by Earfluence. Stay healthy and stay empowered. We'll talk to you soon on STIRRUPS.